You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 10th, 2025. This week, some listener feedback, some corrections, GLP1 use in HFrEF patients, left atrial posterior wall isolation, Peridevice leaks for left atrial appendage occlusion, new findings in post-cardiac surgery AFib, and imaging before AF ablation. First, some listener feedback. I received 2 emails about my coverage of a study of prophylactic pacing after TAVI in patients who have scary, gnarly conduction disturbances. The study was actually a sub-study from the PROMOTE protocol from a Quebec group, which overall is a prospective application of an expert panel algorithm, and it's designed to deal with conduction disturbances after TAVI. The specific paper in JACC, first author Quentin Fisher, looked at 80 of 329 patients who had permanent pacemaker after TAVI. These 80 were put in prophylactically. The authors found that clinical outcomes at a month were similar in the prophylactic versus non-prophylactic patients. However, pacing percentage was dramatically lower in the prophylactic patients, 2% versus 73%, as was the number of patients with pacing less than 1%, 46% versus 14%. The authors concluded that these findings would question the systematic use of prophylactic pacing. And I pushed back in the comments because being wrong about not pacing someone who then collapses and potentially dies from AV block is the same problem with not placing an ICD in a person who has an ejection fraction of 36% who then dies a year later from sudden death. But 2 listeners thought about something that I almost said, but thought that it was too much in the weeds, and I was obviously wrong. Wrong not to mention the fact that pacing percentage less than 1% does not prove that the pacer was unnecessary. And this is because AV block can be paroxysmal, which means that it's intermittent. Without warning, a patient can have 10, 15, 20 non-conducted P waves and asystole enough to collapse. Now remember, the heart beats 100,000 times per day, and even a 0.5% pacing percentage means there's 500 paced beats. So, to Drs. Lucas Plahy in Slovakia and Dr. Evan Marto in Edmonton, Canada, I say thank you for listening and writing to me. Okay, another flub that I made last week was pronunciation, but thankfully it was of a drug in a trial, not a person. The pulmonary artery drug is sotatercept. I also pronounced the Hyperion trial. My gosh, these drugs are hard to pronounce. All right, first topic really is GLP use in HFrEF. I ended last week's podcast with a hint about a possible error I made in the interpretation of a study. I tweeted about an observational study of GLP1 agonist use in patients with HFrEF. Note that GLP-1s have some limited success in HFpEF, such as in the STEP HFpEF trial and in the SUMMIT trial. But the data of these drugs in HFrEF is limited, and the little that there is actually does not inspire much confidence, and more on these studies later. The study in question was also from a Quebec group. It was in JACC heart failure. The title was The Effects of Glucagon-like Peptide Receptor Agonist Initiation in Patients with Heart Failure with Reduced Ejection Fraction and ICDs. Now, device patients are unique in that the ICD is a quite capable monitor. The authors did a retrospective review of outpatients with HFrEF and devices who were followed in their cardiorenal clinics. The comparison was very simple. It was just GLP1 users versus non-users. The endpoints that were assessed were heart rate and relevant arrhythmic events, changes in BMI, and biomarkers. They had 253 patients in total, and they were able to match 53 users with 53 non-users of GLP1s. Matching was simple: age, sex, diabetes, LVEF, and beta blocker use. That's it. No propensity scores, no inverse probability weighting. After adjustment, GLP-1 use versus non-use significantly increased heart rate by 7 beats per minute. That was highly statistically significant. GLP1 use versus non-use was associated with a numeric increase in VT-VF events, 13 versus 2, and a significant increase in non-sustained ventricular events and total shocks and anti-tachycardia pacing therapies. GLP use versus non-use resulted in a decreased BMI and improved glycemic numbers, which you'd expect. But conversely, GLP use versus non-use was associated with a significant increase in NT-proBNP during follow-up. Not mentioned in the abstract but noted in the results was a strong trend for reduction in AF burden in GLP-1 users, which of course probably goes along with weight loss. So my comment on Twitter was that this was a biased, non-random comparison study and that it tells us nothing and probably shouldn't have been done. Because like so many of these studies, a physician chose to use GLP-1s in one group and chose not to use it in the other. And these choices were likely because of differences in patients that could have drove the difference in VT incidence. Yet my friend Andrew Foy, who's one of the strongest thinkers in all of cardiology, I mean it, you should be following Andrew Foy, he disagreed with me and felt like I was too harsh about the study. Foy is concerned about these drugs in patients with HFrEF. He said the authors did the best they could matching, and that a single-center study such as this one may paradoxically be better than a big insurance claims data type study, noting that single-center studies at least have cleaner data. Foy also said that the rise in heart rate is believable and has been shown with these drugs in many other studies, and increasing heart rate in patients with HFrEF is likely not a good thing to do. The strongest part of Foy's arguments, though, comes from a review of the evidence for GLP-1s and HFrEF, which I was really not that aware of. It's kind of old, but let's review a couple studies. There was a FIGHT trial, JAMA 2016, liraglutide versus placebo in patients with HFrEF. It was totally negative for clinical and biomarker outcomes. A post-hoc analysis of FIGHT published in 2022 in Diabetes, Obesity, and Metabolism, looking at total events rather than first events, found an increase in heart failure hospitalizations and total arrhythmia in the liraglutide group. Increase. The LIVE trial published in European Journal of Heart Failure 2016, liraglutide versus placebo in patients with HFrEF. Liraglutide had no effect on LVEF and was associated with an increase in heart rate. Serious cardiac events were also higher in the liraglutide arm compared to placebo. And there was a sub-study of the EXCEL trial, that's EXSCEL trial, circulation. The main EXCEL trial was exenatide in patients with diabetes, and it had no significant effects on MACE. However, there was a signal of lower death and heart failure hospitalizations with the GLP. The sub-study, which was published in Circulation, dealt with 16% of the diabetic patients who had heart failure at baseline in the main study, and they found a heterogeneous effect wherein the 14% risk reduction seen with the GLP on all-cause death in the full study cohort and the 11% risk reduction seen in the subset of patients without baseline heart failure were not observed in patients with baseline heart failure. Bottom line, I learned something from interacting online here. I learned that while GLP-1 drugs may be transformative for patients with obesity and diabetes or atherosclerotic heart disease and obesity or fatty liver, they may not be beneficial in patients with HFrEF. And it makes some sense biologically too, right? Because elevation of the heart rate is a negative for these patients, as well as the fact that patients with HFrEF are surely more fragile than those without left ventricular systolic dysfunction. And so I say thank you to my friend Andrew Foy for this. We actually had a podcast together on Sensible Medicine this past Wednesday about the matter if you are interested. Two quick studies of interest in the AF ablation arena, and they're both provocative because they both kind of go against what we think. Okay, left atrial posterior wall isolation saga. As I have said numerous times on this podcast, PFA, pulse field ablation, has transformed the use of AF ablation. It's faster, cardioselective, and it's associated with less chest pain after the procedure. The speed and cardioselectivity of PFA has increased enthusiasm for doing posterior wall isolation in addition to the standard PVI. Now, the posterior wall sits between the orifices of the PVs. They're right there, and it's quite easy to isolate the posterior wall with PFA. I almost never did posterior wall isolation with RF. With RF, I, like many of my colleagues, except of course those colleagues who came from the lab of Andrea and Natali, we simply did PVI. And we also had evidence, right? We had the Kaplan trial, which showed that posterior wall isolation plus PVI had no benefit versus PVI alone. Now, the lack of evidence for posterior isolation was not the main reason I avoided doing it. However, the main reason I and most of my colleagues avoided doing posterior wall isolation with RF was the possibility of causing thermal damage to the esophagus, which then leads to AV fistula, which then leads to death, and nobody wants to kill patients from an AF ablation. But with PFA, you don't have to worry of the esophagus, and we have bigger catheters that deliver huge PFA lesions, and doing posterior wall isolation is now safe and easy. But there is the matter of durability of posterior wall isolation. So that's where we come to the study in Jackie P. The Sutter Health Group in San Francisco, led by Dr. Christopher Woods, published a nice case series of patients who had, quote, successful endocardial typical PFA posterior wall isolation, and then those patients went on to have epicardial mapping of the left atrial posterior wall during a hybrid ablation. 4 of the 5 patients who had hybrid ablation had successful epicardial mapping during the hybrid procedure, and everyone had epicardial voltage. One patient had even had 64 PFA lesions delivered during the index case and still had epicardial voltage on the posterior wall. So I cover this small case series because A, it supports the contention that the Kaplan study of posterior wall isolation with RF may have failed to improve outcomes because it is near impossible to isolate the posterior wall with endocardial RF. B, this case series shows that even though PFA lesions obliterate signals after delivery, this does not mean that the lesions are durable or transmural. And it may be why PFA versus thermal trials show little to no difference in efficacy for AF elimination. Now, the only caveat not mentioned in this short communication letter is that PFA comes in many varieties in different systems, and these varieties and systems may yield different results. The Sutter Group used the Boston Scientific's pentaspline catheter. Whether different systems with their different black boxes of electrical delivery would lead to deeper or more durable lesions remains to be seen. All right, the second little study in AF ablation that's also provocative and interesting also came from Jackie P., and it was published a small but interesting comparison study from the group of Dr. Natali. Their question was the clinical impact of Watchman device overcompression during implant into the appendage. Specifically, they were interested in the matter of peri-device leaks, which are very bad outcome after percutaneous closure. Of course, you don't want peri-device leaks because any amount of leak means that there could be thrombus and increased thrombogenic properties of the appendage closure. Now, the instructions for use of the Watchman Flex recommend sizing a device to achieve a device compression rate of 10 to 30%. This is a normal amount of compression. However, device oversizing and the consequent device overcompression intuitively reduces the risk of having a peri-device leak. So the group went back and looked at their TEE implant data, and they found that 61 patients were overcompressed and 175 were done as according to instructions for use, had normal compression. There were no differences in procedural complications, and one-year stroke rates were about the same. One-year stroke rates and CV death were 9.8 versus 12%, which is pretty high. Peri-device leaks were less, though, in the overcompression arm. It was 8.2% versus 33%. Let me say that again, 8.2 versus 33%. So I highlight this small study for 2 reasons. One is that overcompression may be better, and good on the Dr. Natali team for doing such work. But far more important is that using the normal instructions for use in 2 of the best labs in the world resulted in 1 in 3 patients who had a peri-device leak at their 2 months TEE. 1 in 3 patients had peri-device leaks in 2 of the best labs in the world. What do you think the rate of peri-device leaks are in the hundreds of small volume hospitals who have also been convinced to do this procedure? Also, what would the peri-device rate be if we looked at CT imaging rather than TEE? My friends, I know that I sound like a broken record, but how is it that our entire field has forgotten that the seminal trials failed mostly because ischemic strokes in the Watchman arm were more than the warfarin arm. Why do you think that is? I'm sure part of the reason is because of peri-device leaks. All right, next topic is post-cardiac surgery AF, and this is a really nice study. German heart surgeons have published this cohort study in JAMA this week on the matter of AFib after coronary bypass surgery. Now, AFib after cardiac surgery is one of the most mysterious and difficult conditions in all of cardiology. Nothing has worked to stop it, so we have pretty much taken the view that after a couple months, the AFib goes away and we don't have to worry. But are either of these dogmas actually true? Does it go away? And do we not have to worry? Patients who have CABG often have high CHA2DS2-VASc scores, so it's not like their risk of stroke, if they had AFib, was that low. This study used event recorders, which are excellent always-on AF monitoring devices. 2 academic centers in Germany had 198 patients who had multivessel CAD and did not have any pre-surgical history of AFib, and they had a loop recorder put in during bypass surgery. The primary exposure that they were interested in was AF detected within a year of the loop recorder placed during surgery. The findings were interesting. First, 95 of the 200 or 198 patients had new onset AFib within the first year, and that's not really new information. We know that nearly half of heart surgery patients get AF. But what is new is that the median AF burden, which you can calculate with an ILR, was low. 0.07% with ranges from 0.02% to 0.23%. That corresponded to 370 minutes or 6 hours of atrial fibrillation median. Of the 95 patients who developed AFib, 73 or 77% had the AF occur within the first 7 days. And the time from surgery mattered. The median AF burden in the first week was 3.65%, but this dropped to 0.04% on days 8 through 30, and then subsequently the median was 0% after that. This corresponded to median times of AFib of 368 minutes in the first week, 13 minutes after day 8, and 0 minutes thereafter. The 5 patients who had incident episodes after 30 days experienced 78 episodes with a median length of only 4 minutes. 4 minutes. Median cumulative time to AF in these patients was about 50 minutes. The cumulative incidence of AFib detected with standard monitoring was only 34%, so the monitors found an additional 16% of AFib. After discharge of 198 patients, only 3 had AF longer than 24 hours, and no patient with new onset AFib developed a stroke during follow-up. There were 2 patients who had stroke, but these did not have AFib. That's also an interesting finding, isn't it? The authors concluded that although the incidence of AFib early after CABG is higher than previously reported, the median AF burden is very low within 30 days, and it's minuscule after 30 days. And I like this study. I like it very much. These findings strongly question guideline recommendations regarding oral anticoagulation after post-CABG. The authors note in their intro, quote, current North American guidelines state that it is reasonable to administer anticoagulation for 60 days after surgery and to reevaluate the need for longer-term anticoagulation. And also, according to European guidelines, long-term anticoagulation should be considered for patients with new onset AF after cardiac surgery, both moderate strength recommendations class 2A based on evidence derived from non-randomized studies. And to be honest, I kind of felt like that too. When I see these patients, they're high risk, their CHA2DS2-VASc score is 4, they have AFib. But this data suggests that AF burden is quite low after surgery, and then it falls rapidly within a week. Only 3 of 198 patients had AF greater than 24 hours. That's something. That observation, right, of low burden AFib and AFib going away after the first 30 days, and you combine that with the knowledge of NOAA and Artesia, and these were trials that looked at oral anticoagulation for short duration, device-detected AFib, and it did not provide a net benefit. This all should make us cautious about using oral anticoagulation after cardiac surgery. And surely Surely we should not be giving enoxaparin for AF, which the authors write is not uncommon. My friends, I have to admit, I'm triggered by enoxaparin and AFib in the same sentence. So let's just take a sidebar here to say that if you use enoxaparin or heparin for AFib, you are in an evidence-free zone. It drives me bananas when I see this. I'm like, can you find me any study suggesting benefit to enoxaparin? There isn't any. Now, the authors do tell us of a trial called PACES, which I'll link in the show notes. And PACES will study 3 months of single antiplatelet therapy with 3 months of combined oral anticoagulant and antiplatelet therapy in patients with new onset AFib after CABG. This data makes me even more conservative about oral anticoagulation after post-cardiac surgery AF. The guidelines, in my opinion, are clearly too aggressive. The caveat here, and I have to mention, is that these were CABG-only patients. This data may be different with valvular heart surgery, and these patients might have longer duration AFib, or they might have a higher cardioembolic risk. All right, next topic is transesophageal echo or intracardiac echo to rule out thrombus before AF ablation. Now, one of the dreaded complications of AF ablation is stroke. One way to avoid stroke is to exclude a thrombus before putting catheters in the left atrium. Traditionally, this was done with TE before the procedure. A long time ago, Professor Natali's group was instrumental in showing that full anticoagulation with warfarin precluded the need for TE. That is, if your patient was on warfarin and had therapeutic INRs, then you could just forego the TE. But DOACs have changed the calculus here because there's no way to ensure adequate anticoagulation when patients say they're taking apixaban or rivaroxaban. We can't measure the levels of anticoagulation with DOACs. And many centers still do transesophageal echo before AF ablation. But it's not nothing to do a TE. There's the added cost and the added risk of damage to the esophagus, which I have seen, and of course there are the scheduling issues. Intracardiac echo has now become common, at least in the U.S. I don't know of anybody in the U.S. not using intracardiac echo. Even I use an intracardiac echo. And people have become facile with using ICE. Therefore, it would make sense that if you're looking into the left atrium with ICE in every case, why not use it to exclude left atrial thrombus? Then you could avoid TE. Well, JAMA Cardiology has published an actual RCT comparing TE to ICE from a group in China. It's a really nice question to try to answer with an RCT, but as you will see, it's not an easy thing to get an answer to. The group randomized 1,800 patients to either TE or ICE, so 900 in each group before AF ablation. Now pause there. That sounds like a lot of people, right? Well, thromboembolic events, which was the primary outcome, occurred in 4 patients in the ICE arm and 5 in the TE arm. That's 0.4 versus 0.6%. The risk difference was only 0.11%, and that made non-inferiority because the 95% confidence intervals went from minus 0.84 to plus 0.62. Thrombus was detected in 2% versus 1.5%. That's a relative risk of 1.29, higher for ICE, but the confidence intervals went from 0.64 all the way to 2.6. So that's a lot of uncertainty. ICE also reduced bleeding from the transeptal puncture, and it reduced fluoroscopy time. So my comments. I like the effort of this trial. This is how this question should be studied. But the problem here, and I think it's kind of illustrative, was that you can't really sort out differences between 2 techniques when you only have 4 and 5 events in groups of 900 patients. Don't get me wrong, it's a good thing that we have these few events. I think surely it's due to oral anticoagulation beforehand. But to sort out the best modality for excluding thrombus would require a much larger trial. And of course, I would add a no imaging arm. Keep in mind that even if a clot is seen in the appendage, that doesn't automatically mean the patient would have a stroke during an ablation. Also keep in mind that many shadows in the area of the appendage are called thrombus but are not actually thrombus. So I don't know what the right answer is before AF ablation. We don't image beforehand unless there is extreme worry about clot. And we have not had strokes, fortunately, like almost 0 strokes in years. Some places I've visited, however, image every patient. And what's weird is that I've been to labs in cost-constrained systems and every patient gets a TE. In the US, that would increase costs significantly. I like the idea of using ICE to image the left atrial appendage. If you have it in there, why not get more use from it? But it sure would be nice to have a big multi-center trial. You'd have 3 arms, TE, ICE, no imaging. I don't think we can answer the question with observational studies because there would be too much confounding, not only by patients, but also by centers. So that's it for this week in cardiology. As always, I'm grateful you listened. Thank you for the listener feedback. Remember, if you like this podcast, it really helps to give us a rating, write us a review. This helps others find us. And please keep the feedback coming, and thank you very much for that. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.